Hi, my name is Eudocia Lee. I'm a neuro-oncologist at Dana-Farber Cancer Institute, and I am one of the discussants for Spotlight Session 4. So here are the 4 abstracts that I want to go through briefly before we finish up with a quick discussion at the end. So starting off, Nancy Lin is presenting updated results of tucatinib versus placebo added to trastuzumab and capecitabine for patients with previously treated HER2-positive metastatic breast cancer with brain metastases. This is to update results that were published last year in the JCO. And as a reminder to you all, though you're all aware, tucatinib is a highly selected HER2-directed TKI. The combination of tucatinib with trastuzumab and capecitabine received FDA approval in April of last year for adult patients with metastatic HER2-positive breast cancer, including patients with brain metastases. Efficacy was demonstrated in the HER2-KIME trial, which was published by Dr. Murthy in the New England Journal last year. And what's remarkable about this study is that 48% of enrolled patients had brain metastases. Here we're discussing the updated exploratory analyses of the intracranial and overall survival outcomes in HER2-KIME patients with brain metastases. And as a quick reminder, some of the key eligibility criteria: HER2-positive metastatic breast cancer, prior treatment with trastuzumab, pertuzumab, and TDM1, ECOG performance status of 0 or 1, must have had a brain MRI at baseline, and was allowed to have brain metastases or not have brain metastases to participate in the study. Patients were randomized 2 to 1, being stratified by the presence of brain metastases, with 410 patients receiving tucatinib, trastuzumab, capecitabine, and 202 patients receiving placebo, trastuzumab, capecitabine. And some of the key inclusion and exclusion criteria in the brain metastases subgroup: patients were allowed to have active or treated stable brain metastases, but must have be neurologically stable and not requiring immediate local therapy. And relevant to the next abstract, patients with leptomeningeal disease were excluded from the study. Brain MRIs were obtained at baseline and every 6 weeks for the first 24 weeks and every 9 weeks thereafter. And you can see 117 patients had treated stable brain metastases, meaning they were treated with surgery or radiation. 66 patients had untreated active brain metastases, and 108 had treated brain metastases, but that were progressing and considered active. In terms of assessments, they looked at overall survival, CNS progression-free survival, intracranial radiographic response rates, and intracranial duration of response. Now, here are the overall survival outcomes for all brain metastases patients. And we can see with an additional 15.6 months of follow-up that we're seeing an overall survival benefit with the addition of tucatinib, 21.6 months versus the placebo trastuzumab capecitabine arm, 12.5 months. That the overall survival benefit is seen in both those with active brain metastases as well as those with stable brain metastases. Here's the CNS PFS for brain metastases patients. Again, though the entire group, those with active brain metastases and those with treated stable brain metastases. In terms of response rate and duration, we can see that the response rate is higher in the tucatinib arm, 47.3 versus 20 in the placebo arm, and that the duration of response is longer as well in tucatinib arm, 8.6 versus 3. So the authors conclude that with this additional follow-up time, that tucatinib, trastuzumab, capecitabine resulted in an improved overall survival benefit of 9.1 months in patients with brain metastases. That the duration of response intracranially was nearly 3-fold higher in the tucatinib arm, and that tucatinib treatment led to a clinically meaningful benefit in CNS PFS. And this analysis demonstrates that tucatinib, trastuzumab, capecitabine is an active regimen for active and for stable brain metastases in patients with HER2-positive metastatic breast cancer. Moving on to the next abstract, This is looking at the same combination, tucatinib, trastuzumab, capecitabine, now in leptomeningeal metastases. Dr. Murthy is the first author. This is an investigator-initiated phase 2 single-arm study enrolling adult patients with HER2 positive metastatic breast cancer, KPS of 50 or better, newly diagnosed untreated leptomeningeal metastases as demonstrated by positive CSF cytology and or radiographic evidence of leptomeningeal metastases plus clinical signs and symptoms. Brain metastases were also allowed. The primary endpoint was overall survival, and this study planned to enroll 30 patients. They were assessed by MRIs of the entire neuroaxis, by neurologic examination, and by extracranial imaging as well. There were additional blood and CSF correlative studies and quality of life and symptom burden questionnaires. 17 patients were ultimately enrolled, but due to lack of accrual following the FDA approval of tucatinib, the study was terminated early. And here are the results. We can see the baseline disease characteristics of this patient population, with most patients having symptoms attributable to leptomeningeal metastases, most having a prior history of brain metastases, and most patients having brain MRI evidence only of their leptomeningeal disease metastases. 65% had extra CNS disease at the time of enrollment. And in terms of results, with a median follow-up time of 18 months, the median overall survival of this cohort was 10 months, and the median time to CNS progression was 6.9 months. So the authors conclude that with the median overall survival time of 10 months, that this compares favorably to historical control of 4 to 5 months. This is indeed the first prospective evidence of clinical benefit with a systemic regimen for HER2 positive leptomeningeal metastases. The safety profile of this cohort was similar to prior studies of this combination. These authors had previously demonstrated that tucatinib and its predominant metabolite ONT-993 is detectable in CSF. And obviously further studies evaluating CNS penetrant oral drugs in this rare patient population are indeed needed. The next abstract is Gaia Griguolo's response according to revised RANO criteria is associated with overall survival in breast cancer patients with leptomeningeal metastases. So just to describe a little bit of the background for those of you who are not familiar, ESMO-IANU provides leptomeningeal guidelines and defines specific subtypes of leptomeningeal disease based on CSF, clinical symptoms, and imaging findings. Type 1 being positive CSF cytology, type 2 being equivocal or negative CSF cytology, but with clinical and MRI evidence of leptomeningeal metastases. And then these can be further subclassified according to their imaging findings, with type A or subtype A having linear contrast enhancement only, B, nodular enhancement, C, both linear and nodular, and D is neither. And you can see that the revised LANO criteria mimic these guidelines, really focusing on whether patients have nodular disease, whether that's improved or not changed or worse with respect to their linear enhancement, similarly improved, no change or worse. And then you look in your brain and your spine. Now, further validation of these revised LANO criteria are needed. Emily LaRue and colleagues have looked at these ESMO-IANU leptomeningeal disease subtypes to further determine, do they have prognostic significance? So they did a retrospective analysis of 245 patients with leptomeningeal metastases from solid tumors. It did include breast cancer patients, lung, and melanoma. And what they saw is that patients who were type 1, meaning have positive CSF cytology, at least in their cohort, had a poor prognosis. And those who had nodular disease in the type 2 setting, meaning that they had equivocal or negative CSF cytology, that those with nodular disease had a poorer prognosis. things associated with better prognosis, having had received systemic therapy. And when looking specifically at breast cancer patients, they found that breast cancer patients tended to have type 2, meaning equivocal or negative CSF cytology, and that the most common imaging pattern was type D, having neither linear nor nodular appearance. So with respect to this abstract, the aim was to validate the prognostic impact of response as per the revised LANO criteria in breast cancer patients. So here they performed a retrospective analysis looking at consecutive breast cancer patients with leptomeningeal disease at these two institutes between December 2005 and June of 2018. They found 225 patients. Of those, there were 142 who had an available baseline brain MRI. And then of those, 60 had had a follow-up brain MRI. So those with the baseline plus follow-up brain MRI were evaluated by a dedicated radiologist using the 2019 revised LANO response criteria. Here are some of the clinical variables, and just to describe this chart, here's the overall patient population, everyone who had had that baseline brain MRI, and then they broke those up into either those who had never gotten any follow-up brain MRI, 82 patients, and those who did get a follow-up brain MRI, and that's 60 patients. And as you can imagine, if you look at this bottom line, looking at median overall survival, the median overall survival of those who had never gotten a follow-up brain MRI was 2.1 months. Presumably these were patients who died before they were able to get a brain MRI, or just clinically not doing well enough to be able to get a brain MRI, versus 15.2 months in those who had obtain at least one follow-up brain MRI. Again, comparing the follow-up brain MRI group to the no follow-up brain MRI group, some of the other clinical variables that seem to be associated is the patients with the follow-up brain MRI tended to have HER2 positive disease. And in terms of the ESMO leptomeningeal subtype, it seemed to trend towards patients who had both linear and nodular disease. Now, here are the results with respect to overall survival in patients with follow-up brain MRI. Again, those are the 60 patients who had baseline and follow-up MRI and had their response assessed by a radiologist according to the revised LANO criteria. Now you can see complete response was a pretty small number with 2 patients, but there was a statistically significant difference between those patients who had a complete response compared to those who had progression of disease as their best response, as it would make sense. There didn't seem to be much separation, though, between the partial and the stable disease. Some of the other results, they found that the presence or absence of a positive CSF cytology did not seem to impact overall survival, which is a little bit of a different result from the Emily Leroon paper that I mentioned. Similarly, these authors did find that systemic therapy and hormonal therapy were treatments associated with better overall survival. And so they conclude that the 2019 LANO revised response score was associated with overall survival in patients with leptomeningeal metastases from breast cancer. Okay, and the last abstract I wanted to go through briefly is Michael Dugan's characterization of HER2 amplification in the cerebral spinal fluid of patients with leptomeningeal disease in stage 4 patients with breast cancer. So again, just a little bit of background on some of these newer technologies with CSF liquid biopsies. As you all know, there's limited sensitivity to CSF cytology with perhaps a false negative rate of around 30%. The 2 main technologies that are being used now to try to improve upon that, to be able to better characterize the CSF in leptomeningeal disease, are circulating tumor cells and cell-free DNA. With circulating tumor cells, studies using cell search or immunoflow cytometry techniques have reported higher rates of detection of CTCs than cytology at first lumbar puncture. You can imagine you can use this technology to assess for molecular markers or even quantify for response assessment. With cell-free DNA, the DNA could be amplified for sequencing, and we can even consider that this technology could be used to look for actionable mutations in patients with leptomeningeal metastases. So with respect to this abstract, the purpose was to examine the ability of their assay, CNSide, to selectively enrich CSF tumor cells and assess HER2 gene amplification or copy number gain. In breast cancer patients with LMD, they looked at CSF specimens from 77 unique breast cancer patients with suspected LMD using their assay. And they also further characterized the HER2 status of the cells using FISH probes for centromere 17 and HER2. So with their assay, in 57 of 77 samples, that's 74%, they were able to demonstrate the presence of metastatic tumor cells. They were able to quantify the number of tumor cells recovered in the single tube of CSF. Of the 57 patients in which they were able to find tumor cells, 32 demonstrated HER2 amplification by FISH. So in conclusion, the authors state that in their subset, HER2 amplification is frequently found in breast cancer patients with LMD and can be reliably detected in tumor cells isolated from the CSF. But they also state that additional studies are needed to fully establish the clinical utility of their assay when using various anti-HER2 therapies in patients with breast cancer LMD. So I just wanted to quickly end on a couple slides, just trying to tie everything back together. So we've made a lot of strides, hopefully, in the field with respect to CNS metastases. And historically, as you know, that patients with brain metastases and leptomeningeal metastases have been excluded from clinical trials. We're certainly seeing perhaps more trials with brain metastases, but still leptomeningeal metastases are often excluded. And really, it's important to really think about including these patients. Here is a perspective piece published by Maurer, Beaver, and Pazder, really emphasizing the need to include patients, particularly if there's a strong rationale for the likelihood of CNS activity. And as you all know, the FDA does now provide guidance for evaluating cancer drugs in patients with central nervous system metastases. And now we have an example of a drug that's gone through that process and has that FDA indication in with tucatinib for HER2 positive breast cancer with brain metastases. The RANO Brain Metastases Working Group has previously published multiple ways that we can think about incorporating brain metastases patients into clinical trial design. So I encourage you all to really think about including your brain metastases patients and even your leptomeningeal disease patients when appropriate and in your clinical trial and even in early phase trials. I do want to finish up as well, talking about some of the challenges that we face with particularly leptomeningeal disease. As we just mentioned, there's limited sensitivity from CSF cytology and the limited ability to perform molecular testing on CSF cytology. But hopefully, as one of these abstracts that we discussed, that CSF liquid biopsies can help overcome some of those challenges, perhaps by providing quantification for assessing response and progression, providing the ability to do molecular testing. And we can even think about doing molecular testing for eligibility, say to make sure someone has HER2 positive disease in the CSF, make that we're treating those patients appropriately. And we can even think about using these technologies to determine why someone develops resistance. With respect to radiographic assessment, as you all know, we still need to further refine and validate LANO. It's difficult, as you all know, because there can be false negatives where there's no MRI findings. And sometimes radiographic findings do not always correlate with clinical findings. So it's important to really develop a clinical assessment tool, and there is a nano for leptomeningeal disease that is being further developed. And finally, one of the issues that we have is that we don't really have good historical controls for leptomeningeal disease trials. How do we know if one therapy really is better than another? And so this is just a little plug to see if this, as a community, we can really think about establishing an international database of LMD outcomes. So with that, I thank you for your attention. And again, I congratulate the abstract authors on their excellent presentations.